Ma'am, you have to unmute.
Sorry. Good evening and welcome all on this Zoom platform of Maha. We are conducting this activity of mentor and mentees on the platform of Maha every month, first Friday. In this, we involve one person as mentor and 3 other people who will be presenting, and we'll be have an overall discussion about that topic, and we get all the insights on the related topic. So today's topic is tropical infections. The idea of this mentor mentees and this concept is suggested entirely by Dr. Mahesh Mohite. He is also joining with us. And today we'll be having esteemed speakers, Dr. Tanu Singhal Madam, Dr. Pramod Kulkarni, Dr. Sudhir Sane Sir, and Dr. Sanjay Nathu. All of them are stalwarts in their field of study. So we'll like to hear from all of them and learn many things. I'd like now to hand over the mic to Dr. Gangolia Sir. He will welcome the speakers and we'll start.
Thank you, Madam. Good evening and namaste to all the respected faculty, Maha office bearers, coordinators, Maha Maha Women Committee, and all the attendees on this Zoom and Maha YouTube channel. I would like to request to all attendees as well as those who are there to subscribe Maha YouTube channel so that one gets the notification of forthcoming session. As well, all this session of this year, which we had held, are there on Maha YouTube channel, so one can watch and rewatch to get the things learned once again. We welcome excellent faculty. We are having Dr. Tanu Madam, the academician of its own kind, as well as we are having Dr. Sudhir Sane Sir, Dr. Sanjay Nathu, Maha EB, and Dr. Pramod Kulkarni Sir, who is a EB CIAP, as well as we have excellent faculty. Also, I welcome our CIP EB member, Dr. Sanjay Deshmukh, my Secretary General, Dr. Amol Pawar, as well as Maha One Committee Chairman, Dr. Renu Boralkar, and all others who are ever is present here. And I'm very sure this session will be with such an excellent faculty. We will have an enlightened session. Will help us to learn the advances in tropical infection, which will be coming in the coming days. So with that, wish each one and all a happy learning, and let us learn more new things from you all, the excellent faculty. Thank you very much.
Thank you, Gangolia Sir. As Sir said, we are dealing with tropical infections day in, day out, but still every day we want to learn something new. So these speakers will be guiding us. Now I welcome Dr. Sanjay Deshmukh Sir to introduce all the speakers. Dr. Sanjay Deshmukh is joining from Nagpur. He is EB member CIA. Welcome, Sir, and you can proceed.
Good evening, all respected Maharashtra IIP members, respected Maha IIP President Dr. Hemant Sir, our own Dynamic Secretary Dr. Amol, and the consulted by Dr. Mahesh Mohite Sir, and all respected faculties. I am very fortunate to be part of this unique program which is conducted by Maha IIP every Friday. And today it's a great thing to have the very interesting topic on the tropical infections. And it will be the great academic session by all the stalwarts today they are having along with us. We have Dr. Tanu Singhal Madam. Madam attached to the Ambani hospitals, and Madam special area of interest is all this tropical infection, tuberculosis. Madam is a member of the RNTCP board also. And then we have our respected Dr. Pramod Kulkarni Sir. Sir is a executive board member along with me from Central IP. Sir is vast experience in all the infectious disease. Then we have our respected Dr. Sudhir Sane Sir. Sir is from leading pediatrician from Thane. Sir is attached with the Jupiter hospitals. And we have our Puneri Dr. Sanjay Nathu sir. So I welcome you all esteemed faculties, and I will hand over to session to our respective faculty to have discussion on tropical infection.
Unmute kara, Nilima madam, unmute kara.
Thank you, Dr. Sanjay sir. Now I'll request Dr. Tanu madam to start the session.
Actually, I think I don't have anything to present. So we will, basically we will, review the presentations by the three speakers and then discuss them.
Okay.
Yeah.
I thought you will be giving some introductory remarks and then we'll proceed to anything. That's okay.
No, I think,
Okay.
we'll just start. Yeah.
Oh, okay. Dr. Sudhir Sane, sir.
Yeah, I will start. So I'm
Yes,
I'm going to I will start sharing my screen.
Yeah.
Is it getting shared? The tropical infection?
Yes, sir.
Or
Yeah.
So I think it's a great privilege to be here, and especially speaking in front of Dr. Tanu Singhal and Dr. Pramod Kulkarni and Dr. Nathu and all of you stalwarts. So I thought that I'm going to speak, my topic is restricted to clinical presentations and some case discussions about tropical infection. And what are these tropical infections? These are the infections which are commonly seen in tropical and subtropical regions. But if you really think of it, these were not so uncommon in temperate climates, that means Europe and all, in 18th and 19th century. Have seen this. So right now they are restricted to tropics. However, infections like typhoid, malaria, dengue, scrub typhus, chikungunya, leptospira, we can say that they are really tropical infections. Is my audio clear? Is it coming?
Yes, sir.
Little bit cracking, sir. Little bit cracking.
Okay.
So if you feel, you can close your video and audio.
Okay, I will do that. I think. Okay. Sorry.
Carry on, sir.
Okay, I will see. 1 second. Huh? So what we are going to discuss is all this, and what we have not included in the discussion is actually tuberculosis, helminthiasis, gastroenteritis, including cholera, which can be defined as tropical infections.
Sunny,
and we must know this term was used initially. I don't know how to do that. Just stop video.
Just go to the icon where you see the stop video. Just stop video. That's
okay.
Yeah.
Okay. Is it
yes,
okay
yes.
now?
Done.
Okay.
Done.
Okay. So this term was used initially to protect, kind of to look at the health of settlers from Europe to India in British Raj. So in fact, I just wanted to have this, I thought of this question, that any time in any have a diagnosis of tropical infection? Not really. So what is tropical infection for me is an perspective. It's like someone saying 6 and 9. So what is the difference in perspective? That tropical diseases has connotation of an outsider's perspective. How a European or a Britishers will review what infections are occurring in tropic, whereas we who are staying in tropic and subtropics, the way we are insiders, and for us these are our day-to-day infections, and these are all community-acquired infections. So what is peculiarity of these tropical infections are, they are usually seen with or after monsoon, and many of them are vector-borne. So with this brief introduction, I want to say that clinical approach to patients with tropical infection, it's useful to have a syndromic classification of presentation. And there is a reference for that. Indian Society of Critical Care Medicine says that it is better to divide tropical infections. So any patient with, say, fever of some etiology into 4 main kinds. One is undifferentiated fever, and undifferentiated fevers can be of various durations, and we'll discuss that quickly. Then the other syndrome is fever with rashes, including clinical or subclinical laboratory diagnosed thrombocytopenia, fever with encephalopathy, and fever with respiratory distress. And let's see how we will have an anatomical approach with that. So let's take this case of a child who is 5 years old, has 102 degrees fever, no respiratory or GI complaints, and has headache and has fever for 1 day only. And as we all clinicians know that the possibilities are many. It can be just common viral infection, common bacterial infection. It can be malaria, dengue, diagnosis. So remember that this child is clinically stable, sensorium is good, general appearance is good, and rapid cardiopulmonary assessment says that it is clinically stable. So how do I deal as a pediatrician into this kind of scenario? So I quickly look at what is current epidemiology. So in patients, say for example, we have just suffered that during 3rd wave of COVID-19, all the patients with fever, that was very high in my list of differential diagnosis, that whether this is COVID-19. The same thing happened during influenza. So what is current epidemiology? Then what I will do is I will just quickly look into family history and any contact of any viral infection or something like that. Having done that, then I will carefully look. There are no obvious symptoms of any respiratory or gastrointestinal symptoms, but I will look for, are there any subtle clinical signs? And then what I will look for flushing. I will look for subtle signs of upper respiratory tract infections like recent onset of snoring or mouth breathing. And then, of course, this is not in the scope of my talk, but what I will do is explain danger signals and need for follow-up and probably give symptomatic treatment most of the times. As we all know that this patient usually doesn't deserve any antibiotic or antiviral, except in exceptional situations, which probably can be discussed later. And investigations will depend on clinical, social, and epidemiological factors. So nothing, no kind of one-time rule can be given. Let's take further this syndrome of undifferentiated fever. And now this child has got 3 to 5 days of fever. And we know that as astute clinicians, relevant epidemiological and social data is very important. What is the current infection in my area? What is this child's family and the things what I told you before? But look at the trend of fever. Now by 3 to 5 days of fever, trend of fever will get obvious. And we know these 2 patterns of obvious fever, that day 3, day 5 decreasing grade of fever, we would label it as viral fever. If the child is clinically stable, then I think we will just follow him up. But whereas on day 3, day 5, if the child has got increasing grade of fever, then I might think that it's a bacterial infection or something also developing. Look also at associated symptoms. And before that, we always know now that biphasic fever, think of viral infection, classically dengue, but many other viral infections and including sinusitis can present with biphasic pattern of fever. And look at irregular trend of fever, which might be classical in malaria or falciparum malaria, and you should look for. I also carefully analyze what are associated symptoms. And once I see associated symptoms, then I try to think what is the trend of associated symptoms. And let's see that the black arrow tells me what are the associated symptoms, and the triangle tells me the trend of the fever. So let's see, in this particular child, the child started having fever. I've seen the child on 3 to 5 days. The grade of fever is decreasing, but the associated symptoms, let's say cough and cold or vomiting and loose motion, started on day 1, day 2, and they are increasing. This is the common viral common infections that we see in our routine clinical practice. Whereas, let's see this pattern of fever where the associated symptoms, this child had cough and cold or maybe loose motions for 4 to 5 days and started having fever after third or fourth day. So first where the associated symptoms and fever started, I think I will commonly think of either unrelated fever or maybe a complication like say sinusitis developing or otitis media developing in a child who had upper respiratory tract infection. Let's see this kind of pattern of fever, whereas there is a continuous fever for 4 to 5 days. The child had some symptoms, maybe vomiting and loose motions, lasted for 1 or 2 days, but unexpectedly, what we would have expected is fever to go and the symptoms to continue. This child's fever persisted, but the associated symptoms vanished. And the other pattern of fever was continuous fever, and the symptoms started after associated symptoms started rather late in the course of the illness, maybe after 5, 6, 7 days. And both these patterns of fever are classically, they can suggest possible entry fever. So the fourth graph, that means the symptoms coming little late can occasion, the third graph can occasionally be parenteral fever, like otitis media or pneumonia can initially present with some gastrointestinal symptoms. The symptoms vanish, but the fever subsides. So I think we should think of onset, duration, progress, and the trend of associated symptoms and correlate that with the trend of fever. Let's discuss fever which goes beyond that. And I have this patient which I saw in 2020. This child, 13-year-old male resident of Ulhasnagar, came with biphasic pattern of fever. And if you see that there was fever for 3 days, then there was rather long gap of 4 days, and then the child started having fever. Initial fever was very high grade. Subsequent fever was moderate to moderate grade, had severe body ache, and the fever was almost continuous later, was responding to antipyretics. Child was active interfebrile. Additionally, child had localization in terms of severe difficulty in walking due to apparently left knee pain. On clinical examination, the child was febrile. There was no localization. Ear, throat was normal. Spleen was not palpable. Although the child was limping, there was no muscle tenderness. There was no restricted range of movements, and reflexes were normal. I saw what was the labs which were done before, and lab showed the CBC showed leukocytosis. CRP was moderately elevated, 76. Vidal was positive, but it was by slide method, and SGOT was borderline, slightly more than SGPT. ESR was not done. But what was surprisingly, because of the pain, someone had done CPK, and that was high. So what were the differential diagnosis? Again, this is tropical, came during monsoon, fever for more than 10 days, biphasic fever. So I thought it would be benign viral myositis, but it was odd because no muscle tenderness, and it was rather too prolonged for benign viral myositis. Could it be dengue fever? Again, too prolonged. Dengue fever usually doesn't last for more than 7 days. CBCs are against. Was it some autoimmune process? Possible, but at present there was no rash, no muscle weakness for dermatomyositis. So, and was it spinal or hip joint infection? To be considered because he has unilateral pain and difficulty in walking. But why the CPK was high? And for GBS, unilateral again, but reflexes are present. So in such a situation, it is always better to go back and take the focused epidemiological history. So there was no history of fever and fever contact in past 2 weeks or 2 months. And this was typically the things that we are asking to with COVID epidemic. There was no COVID-19 contact. There was no animal contact or travel. But he played football with fresh mud, and after that. So with this, I thought, whether are we dealing with leptospirosis, and am I justified in thinking about leptospirosis? So I looked at the modified Fain's criteria for leptospirosis, and if you see that this child had fever, myalgia, history of rainfall and contact with contacted environment. So I've got hardly total score of 15. So not even presumptive diagnosis of leptospirosis. But since we were looking at something unusual, I thought we'll ask for IgM for leptospirosis. So I thought of whether it is recovering viral fever, whether it was autoimmune. So I asked for some tests. Most of them come negative, but leptospira IgM first test came equivocal, 9 OD units. And I started a patient on amoxicillin. The child's fever subsided. That was, probably coincidental. I did repeat IgM after 15 days, and it showed increasing titer of 15 minutes. So now looking at it, if IgM comes positive, now I have a reasonable suspicion of leptospirosis. So friends, this is the difficulty in diagnosing such illnesses like leptospirosis, tropical illnesses for us clinicians. Moving on quickly to second syndrome of fever with rash, including thrombocytopenia. What are the things that we think of? Dengue, malaria. Entry comes with laboratory thrombocytopenia, typhus fever. Various viral exanthems can come with fever with rash, not thrombocytopenia, and scarlet fever, hand, foot, mouth disease. And I just wanted to share this patient was 4 years old, was referred by a pediatrician for continuous fever. 6 days, even after the rash appeared on day 1 of illness, there was no cough, cold, there was no coryza. CBC was absolutely normal. There was morbilliform rash on both the extremities. There was palmoplantar rash, and this child turned out to be rickettsial fever. There was history of contact. This child had gone for hiking in Yeur forest in Thana. Again, this child, most of my friends will recognize this as a classical skin rash of rickettsia. This child had rather severe rickettsial encephalitis with myocarditis. The child has come from a rural area with household contact of animals, and one can see that typical, kind of rashes, vasculitic rash on the ears. And most of you would remember that ear rash is quite typical, vasculitic ear rash is quite typical of rickettsial fever. We don't have to say this, the fever for 4 days, 8-year-old child, blanching rash. This is typically what we'll be expecting. We are started seeing some of these cases now, and we'll expect to see more cases like this in and after monsoon. This is dengue fever. What about fever with encephalopathy? Dengue fever, typhoid, typhus fever, malaria can come with encephalopathy, which is associated with fever. And of course, we should have a differential diagnosis of usual infections like encephalitis, like HSV, Japanese B encephalitis, influenza. We also have to consider metabolic and autoimmune encephalitis. And I just want to have this 8-year-old girl who came recently with sudden onset of high fever for 1 day with convulsions. There were multiple generalized tonic and clonic convulsions, no recovery of consciousness between. It was acute encephalitis. MRI showed basal ganglion changes, subsequently diagnosed as JAP-B encephalitis. So we keep on seeing such kind of cases, especially during monsoon. This was out of season case, but we can have. The third kind of clinical presentation is fever with respiratory distress, which includes ARDS. And we know that leptospirosis, influenza, typhus, dengue, falciparum malaria can come with fever with respiratory distress. And other things that we might think of in a relevant epidemiological conditions will be Legionella infections and melioidosis. And we will not discuss much more about that. One of the last case that I want to talk about is a 13-year-old girl, which I just saw last week. She had fever for 3 days, blanching rash, NS1 was positive. Mother was identified with dengue. And this is another thing that we see during monsoon and during the season of high epidemics, that apparently non-infectious fevers also can come with multiple family members getting affected. Malaria, dengue, and sometimes typhoid. Multiple family members can fall sick at the same time. She was admitted on 5th day due to warning signs, appropriately treated. Fever continued to have fever for 8 days and beyond, and in fact for 10 days. And this was not really typical of dengue. On 6th or 7th day of fever, the grade of fever was very high. I noticed that there was, kind of coated tongue, centrally coated tongue with peripheral redness. Blood culture was sent and thought whether it was a double infection. IV Ceftriaxone was started. Blood culture came positive after 36 hours. So I just want to highlight this, that during monsoon, when there is load of infections are very high, occasionally we see double infections, and as clinicians, we should be aware of that double infections can occur. However, always remember that dengue fever going on within more than 7 days, look for other complications of dengue, like if HLH is developing, whether there is thrombophlebitis, something else that is happening, whether it is drug fever if you are giving drug, but also look for concurrent double infections. Just a last slide on emerging infections. Melioidosis, typically seen from people in farming community, seen some patients who are coming from Karnataka. Look for typical epidemiology and unusual symptoms. Multi-drug resistance typhoid, we see a belt here in western part of Mumbai, Nalasopara, far west, where patients coming from that has ceftriaxone resistant fever, and we should be aware of it. And just last year, 6 months back, we had a very heavy outbreak of chikungunya in Thane. That was the first time that we had such kind of thing. Patients come with fever, and all of you are expert in that, with small joint involvement initially on few days of fever. So we should be on lookout for just this kind of infection. So my friends, this is my algorithm for tropical infections. So have a kind of syndromic presentation, whether it is undifferentiated fever, fever with rash or thrombocytopenia, fever with encephalopathy, fever with respiratory distress. For anything, epidemiological evidence is must. We must try to dig out and look at the epidemiological clues. Look for the trend, look for associated symptoms, look for characters of rash and onset, duration, progression, fever and rash. And most of the times you will get the diagnosis. Then look at the diagnostic possibilities. If unconclusive, relook at the epidemiological evidence and clinical signs. So friends, to conclude, tropical diseases are what common diseases that we see in tropics and subtropics. In England and Europe, they might be exotic infections, but for us, they are day-to-day infections. We have a wide differential diagnosis, including these infections and common routine infections, like including influenza that occurs in my country. So everything comes in differential diagnosis when the patient comes. It is preferable to have syndromic classification and approach, and we look out for multiple infections. What is limitation of my talk? That I have only taken febrile tropical infections. I have not taken non-febrile tropical infections. I've dealt with only common infections. Many cases such as tuberculosis, cholera are left out, and no discussion on helminthiasis, but that is an important neglected tropical infection. Thank you very much. And I would request comments from the faculty, Dr. Tanu, and also any questions. Thank you very much. Should I stop sharing?
Yes, sir.
So how do we go with it, Dr. Nilima? Should I give my comments now?
Yes, ma'am. You can give some comments and then we'll go to the next presentation.
Okay. So thank you, Dr. Sane, for nicely, telling us about a clinical approach to tropical infections. And I think you have covered most of the points. I just want to add a few points to what you said. So in terms of the history, whenever we take a history, I think a history of travel is also important. You mentioned that later about that patient with rickettsia who had gone traveling, but it's very important that you ask where the patient has been in the past 1 month, because sometimes they may not offer and tell you, and we've often picked up rickettsia like this. The second is a vaccination history for typhoid is also important, because of course we see paratyphoid, but if the child has been vaccinated with the current conjugate vaccine, then typhoid becomes a lower possibility. Another factor which I often ask for is ingestion of a community food or something. Many times these patients give a history they'd gone to a marriage or something and had food there, or if they had diarrhea a week or two earlier and now they've started getting fever, because many times when they get enteric, they get one bout of some GI infection and then they have fever. So these are some subtle things which help. The other things which clinically, people can kind of look at is, one is, the rash, the dengue rash, which you called about, you press your hand on the body. Of course, that's a good thing, but sometimes it can be also misleading, because I've seen that many fair children, when they have high fever, they have a flushing of the skin. And then if you put your hand on them, you will see that typical dengue rash, and that will confuse you. So you have to be careful. It is a useful test, but sometimes it can be misleading. The second point is to look at the conjunctiva very carefully, because, if you have conjunctival suffusion or a hemorrhage, that would point to something like leptospirosis. And now, amongst all these illnesses of fever with rash, we also have to consider MISC as well. Though it is not a tropical infection, but it can present exactly like the other tropical infection. So conjunctival congestion is an important thing to see. The third thing is about the S-char. So if you want to look at the S-char for rickettsia, it is very important that you undress the child, because sometimes it will be present in the genitalia, or it will be present in the thigh, axilla. These are some of the places which you may sometimes miss if you don't undress the child. The fourth important point about clinical examination is to press on the muscles and see. Like you had that patient with leptospirosis. In lepto, you can have a situation where you will just press on the body, and you will find that the patient winces with pain because there's typical myositis there. And vital assessment is very, very important in tropical infections, because sometimes, when the child comes to us in the OPD and is walking and talking, we feel everything is right. But early dengue shock syndrome, the patient can be really well looking. So you have to be very careful to put your hand on the pulse and, check the blood pressure of the child. Sometimes, you may be misled if the patient's fever is rising. You find that there is peripheral vasoconstriction. So you may wrongly think that this patient is in early shock. So that you have to be careful, because sometimes I have admitted patients thinking that their peripheries are cold and clammy, pulse is thready. But when you actually, it's because their fever is rising. So once the fever comes down, they're all fine. So vital assessment is extremely important, and you have to remember these couple of things. Also just one comment about that case of lepto. So we all think of leptospirosis, as a illness where you have either the jaundice or you have renal failure, etc. But remember that in the first 7 days of illness, or sometimes in the first 3 or 4 days of illness, leptospirosis is just like any undifferentiated fever. It's not any different. So you may not necessarily have the jaundice and the other things in these patients. So you should keep it as a differential, even if you don't have jaundice or ARDS. And one more subtle point is about malaria, that what happens is that in malaria also you get rigors. In many other illnesses also you have rigors. But in malaria, the patient is absolutely in between 2 paroxysms of fever. So the child may even go to school, or the person may go to work till the next episode comes of fever with rigors. So that is also something which is a little bit, thing about malaria, though you may not see the typical intermittent pattern. And also that the pattern of fever can be vilified by the antipyretic used by the parents, because, this thing about, the fever, is it getting better or not? Sometimes you may not be able to understand, because the patient is being given antipyretics every 6 hours. So you may not be able to judge. So in that case, I think what I tend to generally ask is that, has the antipyretic use come down? Or I really go into great details about fever in the past 24 hours by hour. Like they tell कि नहीं fever तो ऐसा ही है. मैं पूछती हूँ अभी fever कम हो रहा है या ज़्यादा हो रहा है? नहीं मैडम उतना ही है, वो तो ज़्यादा ही हो रहा है. Because parents will always say that कि वो बच्चा बिल्कुल ठीक नहीं है, then you go into the details and ask कि अच्छा कल कब आया था बुखार, then they will say उस टाइम आया था, फिर कब आया फिर वो बताएंगे, तो you can adjust. So sometimes you will have to spend some time trying to discern whether the fever is indeed getting better or worse, because sometimes the parents can be very casual about that.
Yes.
So I think these are some of the points which I wanted to add to what Dr. Sane said in his.
Madam, headache does have some diagnostic value in this all.
So all patients, with these tropical infections will have headaches, but the important thing is how to differentiate it from a CNS infection is if the headache goes away when the fever goes away. Okay. Then you know that you're not dealing with a CNS infection. Of course, in dengue, you may get intense headache. And you also get this history that if the child retroorbital pain, so if the child moves the eyes, there is pain. So sometimes some of these are subtle things, but headache can be present in almost all the illnesses.
Oh, thank you, madam.
Any reason for decrease in malaria cases, or it is there?
No, malaria is anyway come down in India, because I was just looking at the data. In 2000, we were at 20 million cases per year, and now we are down to 5 to 6 million. So obviously the incidence of malaria has come down, and I think it is because of the vector control strategies, etc. All over the world, it has come down. I think the other reason is probably now it has been replaced by the other vector, maybe the Aedes mosquito is preventing Anopheles from breeding or something. I don't know if there is some interference, because we see, maybe if we see 10 or 15 cases of dengue, we'll see 1 case of malaria. Isn't it true?
Yes.
Don't see so much of malaria now.
Yeah.
Sane sir, you want to say something?
Yeah, I think malaria is decidedly has become rare, but that's why it is also more difficult to diagnose, and that's why we should suspect about it, because occasionally we will get falciparum case, and this falciparum will not have a typical malaria kind of fever pattern. The patient can be sick, and we should be, means our responsibility is much more. Gone are the days when we will give empirical antibiotic to each and every patient. Now we will like to but think of malaria in undiagnosed fevers at least.
No, and actually, though the incidence of malaria has come down, but when you do your initial CBC in any patient with fever, we still ask for malarial parasite. Though, however, less malaria is there, but I think in everybody's prescription, when you do a CBC, you may not ask for CRP, you may not ask for NS1 antigen for dengue, but you will ask for malarial parasite. So involuntary, I think, even though the incidence has come down, we are asking for malarial smear. Do you agree with that you generally ask for malaria?
Yes. All of us do ask.
And malarial CMEs are also going down.
Right. Thank you, madam. Thank you, Sane sir. Now we are going to the next speaker. Dr. Kulkarni, you can take over and start your presentation.
Good evening, everybody. Good evening, Maha IP office bearers, Central IP representative, Dr. Sanjay Deshmukh. Very nice evening to Dr. Tanu, who is mentor of all of us. Now going from the beauty and art of clinical pediatrics towards some evidence-based and mechanical things, that is laboratory investigations in tropical infections. So a very nice start by Dr. Sudhir Sane to tell us about the clues towards possibility of tropical infections in a general pediatrics office. So let us go by the very approach accepted universally and highlighted by Dr. Sane, syndromic approach. There are 5 major clinical syndromes. First is undifferentiated fever of 2 types, one either of short duration, less than 7 days, or can be PUO after 7 days. Second will be fever with rash or thrombocytopenia. Then fever with Rdds, fever with encephalopathy, and fever with multi-organ dysfunction syndrome. As the last 2 are usually seen, last 3 are usually seen in ICU setting and not very common in general pediatrics office, we'll be dealing more with the first 2 of them. So let us look at the again etiological organisms or conditions. Common and often considered are the dengue, chikungunya, typhoid, malaria. Common but less considered like scrub typhus, leptospira, and tuberculosis. Less common but not to be ignored at all. Occasionally, brucella, JE, and rabies. Rare but not to forget melioidosis, leishmaniasis, cryptococcosis, and plague. These are the rare ones, but can't say when you will face them. And the newer ones, everybody is quite aware, COVID-19 related MISC, Crimean Congo hemorrhagic fever, Zika very much reported from Maharashtra, and sometimes recently from Kerala, Nipah. So this is just a list of possible tropical infections, out of which we will be dealing with the highlighted red one, 4 common ones: dengue, typhoid, malaria, and scrub. So diagnosis, how do we diagnose these tropical infections? Number 1, clinical case definition. Second, epidemiological predisposition. Third, specific vector or case exposure. These are the 3 important narrowing down points which will increase the pre-test probability of all these specific and non-specific investigations. So it is a must to narrow down. Then appropriate timing of definitive investigations is very important. As we know, the microbiological aids in the diagnosis or the parameters keep on changing throughout the natural history of these infections. Baseline investigations like CBC, CRP, urine, X-ray chest and ultrasound when needed will be a primary set of investigation usually done by most of us. Then point of care tests like rapid malaria test, PBS for malaria, NS1, dengue, IgG, IgM, Vidal test, Bedfeldt test, though discouraged but done frequently. These are the POCTs done routinely. And the definitive diagnostic tests, which are direct or gold standard tests, which are in fact stains, cultures, antigen test, PCR, or sometimes when you are not helped by these 4, advanced or specific serology can be helpful in specific diagnosis. Investigations are also done for monitoring of a diagnosed disease and evolution of the disease and its complication if they occur anytime during the course. Let us come to dengue diagnostics as the number 1. We know the dengue dynamics, disease and diagnosis. We know the course, 1 to 7 days, days of illness, behavior of temperature, potential clinical issues, laboratory changes, changes in hematocrit, WBC count, platelet count, then the serology and virology, initial viremia followed by IgM and IgG. And course of dengue illness we typically divide into febrile stage, critical stage, and recovery stage or phase. At the end of 7 to 10 days, usually dengue, unless complicated by something else, unusually so, cannot be considered as a differential diagnosis beyond 7 days. Let us come to the dengue changes actually occurring into. So we see the serology, and first diagram of the serological changes is pertaining to the primary dengue infection, while the second one depicts the secondary infection. You can see the obvious change or the differences in that the NS1, which correlates with the viremia, is at height up to 6 to 7 days, best during first 3 to 4 days. The IgM just start rising with the symptoms and turns positive maybe at the end of first week or so, followed by which the IgG rises. In a secondary dengue, the sequence changes because of the previous exposure and previous seroconversion towards dengue, either of the same type or the other serotypes of dengue. Here, the IgM rises earlier. The NS1, though rises earlier, the response is little lower in quantity. Viremia is similar. Then we have the IgG coming little earlier in first few days, and the IgM also little lower one, but the same behavior. So these are the gross differences between primary and secondary dengue and the various phases of microbiological access to the diagnosis. So you will see the virus RT-PCR. On the left side, you see all the tests. And in primary and secondary dengue, their sensitivity and specificity. Virus RT-PCR in first 2 to 10 days, sensitivity in primary is 85%, specificity is 95%. Again, the similar in secondary dengue, so it is highly reliable. NS1 ELISA, 0 to 10 days, though given, it is best up to day 3 or 4. 70 to 90% in primary dengue, and little lesser than that, 60 to 70% sensitive in secondary dengue. Specificity, you will see it is very, very high, more than 95%, a very good clinical aid for diagnosis. IgM MAC ELISA usually starts after 4 days, usually positive by 6 or 7 days. Sensitivity is low, but specificity is reasonable, 95% again. In secondary dengue, again, you will see lower sensitivity of IgM MAC ELISA. IgG, again in primary, sensitivity little better, 70 to 90%, specificity 95%. And in secondary dengue, little earlier, day 3 onwards, is more sensitive as well as more specific. So looking at the green figures of more than 90 to 95%, you will see all these 3 routinely available assays are highly specific and diagnostically useful. Now, interpretation of dengue serology, you know very well, usually a combo of all 3 is done, except the first 3 days. If you stand the chance of secondary dengue, again, the combo of 3 tests is desirable. But if you don't have past history, you can go only for NS1 also. And the interpretation, we are very well used to the interpretations in terms of NS1, IgG, IgM, and early primary dengue, current or recent dengue, secondary dengue, and past infection of dengue. The exception being congenital dengue. We are very well used to this typical table. Okay, so let's go ahead. Now about the rapid diagnostic tests in dengue. Have good specificity, as I said, but very well. See, we are looking at 2 different methods of diagnosis of dengue. Number 1, the gold standard is ELISA. But what we routinely do, and many of the labs do, is the screening test, rapid detection test, which are the lateral flow immunochromatographic test. They have good specificity, but variable and low sensitivities. Fair positive predictive value, but poor negative predictive value. NS1 RDTs perform better than IgG, IgM, especially early phase. New generation combination RDTs have improved performance. Sorry. Commercially available dengue RDTs in India are highly variable in diagnostic performance and are not recommended for routine use, especially if you want to get a confirmed or more probable diagnosis. MAC ELISA quantitative assay of NS1, IgG, IgM are current gold standard of dengue diagnosis. Dengue RDTs, reliability, results and interpretation are significantly influenced by timing of test in the course of disease, method and quality of test, serotype of dengue virus, most sensitive being DEN1 and DEN4 being least sensitive. Primary or secondary type of dengue infection, immune status of host, other flaviviruses in circulation like Japanese encephalitis, chikungunya, yellow fever, and Zika. Pre-qualified new generation combination dengue RDTs can facilitate early anticipatory effective dengue management in remote areas. Now coming to typhoid diagnosis. Parameter, accuracy, limitation, and recommendation as basis for treatment. That is the point for diagnosing typhoid, whether to start the antibiotic empirically or on suspicion. So the clinical parameters, how reliable they are in diagnosis, just 50% toss of coin, non-specific, and can be considered for therapy only if the child is very sick, not otherwise. So in common scenario, we are not supposed to rely on clinical parameters for starting therapy of enteric fever. Vidal test, the most popular one, supposedly the obsolete one, and actually it is obsolete. 60% accuracy, little better than the clinical parameters. High false positive and negative. Tighter cutoffs vary, and they are affected by previous antibiotic treatment as well as previous generation vaccines. Only they are to be referred to only if culture is not feasible or negative or when they have to use only tube method, and paired sera with 4-fold rise is the minimum requirement for diagnosis, which doesn't help at all. So practically it is useless and obsolete. Serological tests, ELISA, IgM based like Typhoid or Vivex have been held up by many laboratories and practitioners and vouched for, but again they are not very, very reliable. This accuracy being just 70 to 90%. There is no robust evidence. Cochrane does not recommend these tests in lieu of cultures to this point. Cannot replace cultures currently. Cultures, these are the gold standard. Urine less than 10%, stool 30%, blood 50 to 60% if you correct it appropriately, and bone marrow, the highest sensitivity 90%. Of course, little difficult and later in the course, not usually preferred by all of us. The sample volume of blood culture or the sample is very, very important. Adequacy has to be ensured. Prior antibiotic reduce yield of cultures, and availability of culture can be a possible limitation in the rural area, but it is the gold standard of diagnosis of typhoid fever to this date. Molecular methods like PCR, though encouraging on viral infections, parasitic infections, on typhoid, they are not very effective, only 30%. And because the bacteria is quite low and there is insufficient DNA to be captured by the assay. It still remains experimental, except the new tropical fever panel which is brought, which can pick up possibly better than in the early course. So some role there, but not a gold standard up till now in diagnosis of enteric fever. Now, malaria diagnosis. So look at all the tests and the benefits. Light microscopy, the gold standard. Rapid detection test, rapid, reliable, various tests available, useful in primary care where microscopy, skilled microscopist is not available, as well as additional tests to PBS in screening. And the PCR, let me tell you, this is the best and most sensitive test, but at current position being used only in public health or research laboratories. But it is very, very promising, including the recently launched global fever or tropical fever panel of multiplex PCR. It's highly sensitive and better than the even microscopy as well. So malaria Rdds, we use them very routinely. Again, they are HRP2 based antigen, parasite LDH antigen or aldolase antigen. Various combinations are available and it is solely up to you to choose. At least 100 different types of Rdds are available, and only WHO pre-qualified should be preferred for use as a screening test or supportive test. Antibody tests are banned by Government of India and WHO. Coming to the diagnosis of scrub typhus, routine hematology, total WBC early could be normal or low with shift to left. Later part, there can be leukocytosis in 1/3 of the cases. Thrombocytopenia is seen quite common in 60% of the cases. ESR non-specifically, like any other illness, is high. Biochemistry, again non-specific. Any capillary leak syndrome with any of these tropical infections will be associated with hyponatremia and hypoalbuminemia, and transaminases rise. It is non-specific. Serology is the only currently available, freely used basis of diagnosis. So various methods of serology: microimmunofluorescence, indirect immunofluorescence, immunoperoxidase, which is a substitute to IFA, latex agglutination, indirect hemoagglutination, ELISA, dot blot immunoassay, and Well-Felix test. All these are methods of doing serology in scrub. These are useful only after first 5 to 7 days. Well-Felix is a heterophile antibody test. Agglutinins to Proteus vulgaris strains are detected. It is poor, it has poor sensitivity, but can be used as screening test. It is reasonably specific if positive. In spite of all its drawbacks, it's a useful and cheap diagnostics tool in peripheral India or the semi-urban or town areas. either fourfold rise in agglutinin titer in paired sera or single titer of more than 320 is considered diagnostic. Use of this test is accepted in conditions where definitive investigations are not available. IFA is available only at reference laboratories, gold standard. PCR, now available at the big cities, is reasonably reliable. The Buffy-Coat smear or whole blood or tissues can be subjected to PCR. It is rapid. Only thing, sensitivity is not very high, but is highly variable. The cost is quite high and availability issues. But when this can be overcome, this is quite useful and very specific. Immunohistochemistry and isolation of organisms are only for experimental and research laboratories. Now let us go to a common scenario seen by all of us. Undifferentiated fever of 3 to 5 days, a stable patient. WBC is normal or decreased, platelets normal or decreased, hemoglobin or hematocrit. These are the basic investigations with which we go ahead. If hematocrit or hemoglobin is normal or increased, do dengue combo test, either a pre-approved rapid detection test or ideally, if available, MAC ELISA, NS1, dengue, IgG, IgM. If it is positive, it confirms dengue. Specificity more than 95%, the dengue is confirmed. If it is negative, possibility of chikungunya remains there, but which doesn't usually need a clinical further microbiological diagnosis unless complicated. Then look at the neutrophil, eosinophils and the CRP. If there is relative neutrophilia, eosinopenia and positive CRP more than 30 to 40 milligram per liter, a surrogate marker of possible bacterial infection, a typhoid chance or rickettsia are likely. In this case, blood culture has to be sent in appropriate way in 2 bottled sets with adequate volume, at least 4 to 5 ml in each of the bottle. If it is positive, which happens many of the times, it is confirmatory favor. If the hemoglobin and hematocrit is decreased, then do PBS for MP and rapid malaria test. If they are positive, malaria is confirmed. If they are negative, again look at the WBC, eosinophils and CRP. If they are suggestive, then do culture. Repeat PBS and RMT second time because maybe you can miss malaria in first sample. So 2 times or 3 times at interval of 24 to 48 hours. If you do PBS and RMT, it practically excludes malaria at least 2 times. Then you can do the PCR, which is available, tropical fever panel or a rickettsia standalone PCR. If it turns positive, you have got diagnosis of positive specific organism. Look for evolving symptoms and signs in the previously diagnosed case by these methods. Look for rash, eschar, erythroderma, hemorrhagic rash, necrotic rash, vesiculobulous rash. Warning signs and whites, bleeding diathesis, new organ or system dysfunction. These are the clinical clues which will dictate your further workup. The selective investigation in such scenario, which can be repeated or done, are repeat CBC and CRP trends. CBC trends in dengue are very helpful. As soon as the platelet starts rising, the patient is in recovery phase. You can stop hematological monitoring if the child is stable. Specific organ functions, LFT, RFT, electrolytes, coagulation profile, sepsis markers and appropriate cultures, and complication of HLH, which can occur in dengue and all other tropical fevers, a set of ferritin, triglycerides, and fibrinogen with cytopenias. This can be taken up if there are clinical clues. Bone marrow or biopsy may be done for diagnosis of the hematological complication or occasionally for confirmation of the infection which is there in macrophages of the bone marrow. Imaging may have to be done, X-ray chest ultrasound for the capillary leak, serositis, ascites, or liver issues, or the pulmonary assessment. Echo may have to be done occasionally for cardiac dysfunction. CT MRI may have to be done rarely if there are clinical indications of complication. Now the second scenario, undifferentiated fever more than 7 days, which comes at CUO.
Dr. Pramod, yes. Actually, I think we were mainly discussing tropical fevers here. So I think we can skip the discussion on PUO.
This is about tropical infection and a brief slide. I'll just go through it.
Okay.
So it is, again, if we go through, if we don't have any clue with the initial workup, look at the organ dysfunction. And depending on the clinical combination of these organ dysfunction, you have got the possibility of the tropical infection with tuberculosis and brucella added as cause of PO and dengue being removed. And these are the various diagnostic tests for these particular conditions. Not to forget the MISC masquerades, and which is to be proven by serology, inflammatory marker, two system dysfunction, and exclusion of others by culture. Not to forget PO, other important causes, rheumatological disorders, and the malignancies. That's all. Thank you very much, mentor, Maha AP, and all my patient listeners. Thank you so much.
Thank you, Dr. Pramod, for that effervescent presentation. Please have a glass of water. You must be tired. You were so enthusiastic in your presentation. I think you didn't even take a breath. So I think you have covered most of the things. I just want to kind of add a few points. The first point is that when do you ask for the investigations? That is an important, because in the tropical season, you have a patient coming in. So usually it is better to ask for the investigations after 48 hours, because in the first 24 to 40, unless the patient is looking sick, because it may be possible that after 48 hours, you may have a localization, you may find that he has flu or some respiratory viral infection. And also the changes in the CBC and other things are not really apparent in the first 2 days. You can get a normal CBC, which may mislead you. That is one point I wanted to make. The second point I wanted to make is the hemoglobin may be misleading in our country, because what happens is that many children who are dehydrated when they're having fever, so you may get a falsely high hemoglobin. You have to keep that into account. And also low hemoglobin may be present just because of pre-existing anemia. So to change your algorithm on the basis of hemoglobin may have its problems. Then, apart from looking at the TLC, I think it is very important to look for some other things like, as you already mentioned, neutrophilic predominance in typhoid fever and monocytes in malaria or viral fevers. And also always look at what a person has said about the peripheral smear. If they said reactive lymphocytes are seen, that is actually a very good marker for a viral infection. So that can help you diagnose viral infections and separate it from bacterial infections. Also, the severity of the low white cell count and platelet counts helps you, because if the white cells and platelets are low very early in the illness, very low, then you know you're dealing with either malaria or dengue. In typhoid, etc., the decline in count does not happen so fast. Then second thing is about the CRP. So I think the CRP is also a good test to do in your first thing. When you do a CBC, after 2 or 3 days, you can include a CRP in that. And if your CRP is negative, then it is more likely viral. And if your CRP is more than 40 milligrams per liter, you could be dealing with enteric fever. So CRP can come in there. About dengue, there's one point I want to mention is about the dengue IgM. That is very poorly specific, because dengue IgM can remain positive for at least a year after infection. So you will often see people who are coming with some other infection and their dengue IgM will be positive. So be very careful. If the other things are not fitting in with dengue and your dengue IgM is positive, think of some other illness and not dengue. So that way, I think NS1 antigen is the most specific for the dengue serology. If after 4-5 days, if your NS1 is negative and you're strongly suspecting dengue, you can ask for a dengue PCR, because that is also a good test. The fourth thing I wanted to mention is about the Typhi.IgM, because that's a very commonly done test in clinical practice, but it's not a good test. Though there are some studies saying that it is good, but we see a lot of false positivity with Typhi.IgM, and many patients with culture negative typhoid have a negative Typhi.IgM. So that's not a good test to do. I find an ultrasound also a good test for enteric fever on day 4, day 5, because sometimes it's very difficult to distinguish. You have sent your blood cultures, the report will take time, or the patient is already on antibiotics. So if you have a good ultrasonologist and they will tell you that there is terminal ileal thickening and mesenteric nodes and a little bit of spleen, that is useful in clinical practice for diagnosis of enteric fever. And sometimes, we have patients coming in after 7 to 8 days of fever when their blood cultures will be negative and they have a normal, unremarkable CBC, mildly elevated CRP. The ultrasound can help you in, as one of the additional tests for diagnosing typhoid. So I think another point I wanted to mention, though you said that for chikungunya, we don't need to do any further tests, but I think you should do it because sometimes it can really confuse you, and you can do a chikungunya PCR that is not very expensive. It is positive in the first 5 days, whereas your chikungunya IgM is later. We've had patients who have come with very high fever, 40 degrees. And chikungunya patients typically can have a normal or raised white cell count and have a high CRP, unlike other viral infections, because there is so much inflammation going in their body. So there, I think a chikungunya PCR, and the same thing goes for leptospirosis. That for leptospirosis, the most useful test is a lepto-PCR because your lepto-IgM positivity is really, it's non-specific. And I think that is what I wanted to tell you, say, in terms of the investigations, that your initial test, which you ask for, is CBC, malarial parasite, and CRP, and a urine routine. These are the first 4 tests you ask for after day 2, day 3. And then on the basis of the results and the evolution of the illness, you can decide to do dengue. Or if you have a dengue season going on, then you will do dengue NS1 upfront. Another thing, what I mentioned about the RDTs is useful, though you mentioned the problems with dengue RDT, is that the turnaround time is very fast. Because what happens is, if you submit a sample for ELISA testing, if you submit it today afternoon, the lab will take it up in the next day morning batch and you'll get a report by next day evening. So if the patient comes to you and you're thinking about dengue, you can do a dengue RDT, and the NS1 is the most specific of them. So if your NS1 is positive, then you know that it is dengue and you will not kind of investigate for other illnesses. So that is the benefit of the RDT, that your turnaround time is faster. I think that is what these are the other points I wanted to add to your presentation. Yeah.
Thank you, Tanma.
Pramod sir, two specific questions. In peripheral limited resource setting where microscopy is very problematic, lots of RDT tests are available. You can just specify the name of the company, which one we should use at our clinic level itself to do the test.
I better not name any company, just see if it is WHO pre-qualified, that's all, or NVBDCP approved by Government of India or WHO, the pre-qualified test. There are tests which carry this mark. If they are pre-qualified, they are reliable.
Okay. Any specific antigens?
No, now we have all the standard combinations which can differentiate Vivex, falciparum, Vivex, and others.
Okay.
No, for dengue, I think PanBio is a good thing. PanBio, we often use PanBio for dengue analysis. And I'll let you know the name of the malaria test during the course. I'll reply to your question. Let me just find out from what I'm using.
And second question is this, though Vidal is obsolete, almost obsolete, we don't use, but at peripheral still, whether repeat Vidal after 8 days and rise of folds, really 4 folds or what folds, is really holds true, or it should not be done at all?
See, basically, getting a diagnosis of typhoid fever is to treat it. If you are not basing your treatment decision on the diagnostic method, what's the use of doing the first test after 7 days and repeating it after 14 daes? By that time, you are already treated the child. So it's not practical at all. There is no use.
And also, when you give antibiotics, they will prevent the rise of the titer. So that was, if you're not, you will start treatment on day 5 or day 7. So once you have started treatment, see, your decision to treat test for typhoid is really not based on the Vidal. It is based on your clinical presentation of persistent fever for 5 to 7 days, toxic look, coated tongue, unremarkable CBC, and high CRP, even if you don't have access to blood culture. So then you base your treatment decision on that.
the worst part of it is you stamp the patient for typhoid and ignore the underlying something else which can evolve over time, and you are just continuing with the antibiotic and missing the very important clues. Everybody must have seen such cases. Vidal positive brought from outside, turning out something else, leukemia, rheumatological disorder, and something else, infective endocarditis. So please don't base your diagnosis of typhoid, because you have to wait. If you label it as typhoid, if you start Ceftriaxone, you are going to wait for 5 to 7 days for a response. By that time, you are not going to change your diagnosis. So that's a masking of your therapeutic decision. Please don't do it.
Nowadays, labs are approaching with Biofiber panel tests. And ma'am, do we have any role of these tests in stable patients, non-ICU patients?
By Biofire, you mean the tropical fever PCR, So that tropical fever PCR is not by Biomilieu. It is by a company called TransAsia. So one thing, so that is a PCR which detects 6 diseases. So it includes dengue, chikungunya, malaria, leptospira, rickettsia, West Nile, and salmonella. These are the 7 diseases which are detected by the test. So in that, West Nile is not common, and salmonella PCR is not a good one, because the Dr. Pramod already mentioned that it's not successful. So you leave those 2 out. So bache 5. Usme malaria is usually diagnosed by your malarial smear. Yes. Okay, so that is out. Your dengue, mostly your NS1 will give you the diagnosis. So those 2 are out. So what you are left with is 3: chikungunya, leptospira, and rickettsia. Okay. So there, yes. So if you have an undifferentiated fever where you can't make the diagnosis, you can ask for this panel. But mostly we ask when we are suspecting rickettsia. Because in rickettsia, this is the only commercially available PCR-based test. And otherwise, you have scrub typhus IgM, which is available, which is again positive after 5 to 7 days. Or you have spotted fever IgM, which is not commercially available. And if you, based on the fever presentation, you can also sometimes decide whether it is looking like leptospira or it's looking like chikungunya. Then you can ask for a specific PCR for them, because the cost of that specific PCR is much lower. Whereas, see, you can get a chikungunya PCR done for 1,500, whereas this panel will cost 6,000 to 7,000. So please understand that the panel is only in those patients where you have not been able to make a diagnosis based on your conventional methods. Like your malarial parasite, your RMAT, your dengue NS1, your scrub typhus. If the patient has an S-char, then what's the point of doing this test?
Right. Thank you, madam, and thank you, Pramod Kulkarni, sir. Now we are going to the next presenter, Dr. Sanjay Nathu, sir. So you can start your presentation.
Yeah, I'll share my screen.
Yeah.
Are my slides visible?
Yes, sir.
Yeah.
Yes,
So thank you, Maha IP, for giving me this opportunity to speak on a stage where Dr. Tanu Singhal, Madam Kulkarni sir, and Sane sir, who are like very eminent and well-known pediatricians and pediatric infectious disease specialists. Thank you for allowing me to speak on this dais. So my job has been done very easy because Dr. Sudhir Sane sir has shortlisted the likely conditions on clinical grounds, and Dr. Kulkarni sir has gone ahead and done relevant investigations and decided what is the likely diagnosis. So what I'm going to do in the next 10 to 15 minutes is a very short presentation just to revise the management protocols for 3 or 4 common tropical conditions which we are likely to face in the coming months. I'll just start with the first one. So the management algorithm with dengue, and we have discussed how the dengue presents, and as madam said, in the dengue season we tend to do the testing quite early in the disease. Maybe day 2 is the usual time when we do the testing, and so we are left with the diagnosis of dengue. So how do we diagnose, how do we treat? It depends on whether the dengue patient is coming with warning signs or without warning signs. So without warning signs, we would preferably send a patient home. Though the patient may pressure us to admit, it is better to send a patient home in such a situation. Who warrants home management? So the child who has no warning signs, one who is tolerating oral fluids and passing urine at least once in every 4 to 6 hours can be sent home. What tests need to be done for this child? Only CBC or hematocrit with hematocrit may be sufficient to monitor the child. What treatment is required? Rest, fluid intake, which should be ensured by the parent and preferably documented, and they should be given an idea how much fluid needs to be consumed. And paracetamol for fever every 4 to 6 hours is all that is required. And monitoring should be done very rigorously with a daily review with the pediatrician. A decreasing WBC count should be watched for, and defervescence, it is the time when most likely the child may develop a critical phase and may present with complications that needs to be watched for. So they need to be told that the child may require admission in case there are warning signs, and it is very important to put in place a written plan for home management of dengue without warning signs. Now, if a child comes with warning signs, or who is the child of dengue who requires inpatient management? So obviously a patient who has warning signs, or maybe a small baby, infant, or a child who has a coexisting morbidity, maybe the one who needs to be managed in the inpatient setting. So the warning signs, all of you are aware: abdominal pain, persistent vomiting, clinical fluid accumulation, mucosal bleeds, lethargy or restlessness, liver enlargement, and a lab showing a very high hematocrit. These are the warning signs which we should be looking for. What tests need to be done for this child? So CBC with hematocrit is all that is required for monitoring as well. What is the treatment if there is no warning signs? So that is for if it's an infant or there's a coexisting morbidity, then of course only rest, encourage oral fluids. And if the intake is inadequate, then you may need to start maintenance IV fluids with isotonic fluids. And of course, paracetamol may be required for control of fever. Monitoring is very important. You need to monitor temperature. We need to find out when the child is going into defervescence. How much is the fluid intake oral and if required IV? What is the frequency and output volume? Daily monitoring for warning signs presence. And of course, we have to monitor for rising hematocrit, falling platelet count which is expected, as well as the decreasing WBC count which precedes the falling platelet count. What if the patient already has warning signs at admission? Then of course you need to document a baseline hematocrit and start isotonic IV fluids like normal saline or ringer lactate at 5 to 7 ml per kg per hour for the first couple of hours, and then go on decreasing to 3 to 5 ml per kg and then 2 to 3 ml per kg subsequently. Of course, you have to reassess clinically and maybe do a hematocrit, and you are likely to get a hematocrit which is same or which is showing a minimal rise. In such a setting, if the output is not adequate, you can continue IV fluids at a lower rate of 2 to 3 ml per kg per hour for the next 2 to 4 hours. However, if there is a worsening of vitals, and this monitoring of vital signs is very important, then you need to increase the IV fluids again to 5 to 10 ml per kg per hour for 1 to 2 hours. Keep on assessing clinically, and hematocrit needs to be done periodically, and then you can decide how to manage the IV fluids. And we have to reduce the IV fluids when the signs of plasma leakage decreases, and this is usually represented by an adequate oral intake and output and a hematocrit which is falling below the baseline in an otherwise stable patient. So this needs to be highlighted: hematocrit falling below baseline in a stable patient. In an unstable patient, if the hematocrit is falling, then we need to suspect bleeding. So throughout this inpatient management of a child of dengue with warning signs, you have to keep on monitoring the vitals, you have to keep on monitoring the perfusion, the output, the hematocrit, as well as the other symptoms, other systems if they're getting involved. For example, the child may be developing a cardiomyopathy or an encephalopathy. Liver enzymes are expected to be deranged in these patients. What if it's a severe dengue? Then of course you need to manage in the PICU, for whom if there's a severe blood loss, severe organ impairment in the form of say myocarditis or encephalopathy, severe plasma leakage with shock and or fluid accumulation with respiratory distress. And these are the algorithms for compensated shock which are available everywhere. I'm not going to go into too much detail with this. So if it's a compensated shock and if it's a uncompensated or hypotensive shock, then how to go about giving the fluids. What if there is a hemorrhage? What if there are hemorrhagic complications? If there's a bleeding? So who are at a risk for bleeding? So those with profound, prolonged and refractory shock, those with multi-organ failure, a child with severe persistent metabolic acidosis, someone who's received NSAIDs or has had trauma or intramuscular injections, or a child who's on anticoagulations for some other reason, this child is likely to go in for hemorrhagic complications. So how do you suspect and recognize? If it's a persistent, severe overt bleed with unstable vitals, then of course that is very obvious. Unstable hemodynamics, that is very obvious. If there is a decreased hematocrit after fluid bolus and the hemodynamical the child is unstable, then you need to suspect whether the child is having a bleed. A shock which is refractory to your treatment should raise a suspicion of bleed. hypotensive shock with a low hematocrit, because in dengue we can expect hypotensive shock with a high hematocrit. So if there's a low or normal hematocrit and a hypotensive shock, then again you should suspect hemorrhage, or a worsening metabolic acidosis in a well-maintained systolic BP, especially with severe abdominal tenderness. Sometimes these children present with GI bleeds, giving rise to severe abdominal tenderness, and this is where you need to suspect and recognize bleeds. How do you treat? So if it's a mucosal bleed only in a stable patient, usually it's a relatively minor issue and you need not do anything actively. If it's an obvious bleed, attempt to stop bleeding if feasible, if it is accessible. Replace blood loss if you can estimate the amount of blood loss. However, if it is non-quantifiable, then you can give 5 to 10 ml/kg of fresh PRBCs, and preferably fresh PRBCs are to be given. Repeat the PRBCs if there is overt blood loss or there is no appropriate improvement in hematocrit in an unstable patient. Platelet and FFP do not have much role in management of bleeding in the case of dengue. Coming to malaria, there was a question in the chat box by Dr. Deshmukh, do we see malaria in metro cities? So from Pune, I can say, and I'm sure Dr. Kulkarni will agree that we hardly have seen malaria in the last year or two. I do not remember seeing a single case of malaria in the last couple of years, but that doesn't mean we should remain complacent. So if it's an uncomplicated falciparum malaria which has been diagnosed and it is defined as the symptoms of malaria and a positive parasitological test without features of severe malaria, then how do you treat? The gold standard is treating with one of the artemisinin-based combination therapies. So there are various options available, but as I was discussing with Dr. Kulkarni in the morning, the only one which we commonly use in our daily practice in an uncomplicated falciparum malaria is artemether lumefantrine. In fact, I would like to know whether from the experts whether the other tests are easily available and what is their role in children. But artemether lumefantrine is very commonly available and used. How long to be given? So 3 days. What are the doses? It depends on the body weight. So it is given twice daily for 3 days. Preferably the first 2 doses should be given 8 hours apart. And depending on the body weight, you can decide the dosage. If it's a severe malaria, so what is severe malaria? These are all the signs of severe malaria: impaired consciousness, prostration, multiple convulsions, acidosis, hypoglycemia, severe malarial anemia, renal impairment, jaundice, pulmonary edema, significant bleeding, shock, and hyperparasitemia. So these are all signifying severe malaria. How do you treat? Treatment of choice is preferably, it is imperative to give parenteral artesunate for at least 24 hours or till the child is taking orally, followed by artemisinin-based combination therapy for 3 days. The dosage of artesunate is important. It is 2.4 mg per kg per dose at 0, 12, and 24 hours, and once daily then subsequently till the patient starts taking orally. An important point to be remembered: for children weighing less than 30 kg, artesunate dose is 3 mg per kg per dose and not 2.4 mg per kg per dose. We all know it is dispensed as a powder to be dissolved in sodium bicarbonate and then subsequently diluted in 5 ml of 5% dextrose and subsequently given IV or even IM on anterolateral thigh. And a freshly prepared solution is to be used, not one which is prepared a long time back. I am not going to again go into details of how are the complications to be treated because each complication needs to be handled separately. Now, what if it's a Vivex malaria? Vivex malaria is usually uncomplicated, though complicated Vivex malaria also occurs. And the treatment of complicated Vivex malaria is just like falciparum malaria. For an uncomplicated malaria with Vivex, in a chloroquine sensitive area, the idea would be to give chloroquine 25 mg per kg per base over 48 hours at 10 mg per kg, 10 mg per kg, and 5 mg per kg at 0, 12, and 24 hours. Or an artemisinin combination therapy is one which is preferred because that brings about a uniformity in the treatment of malaria. If it's a chloroquine resistant area, then the default choice is artemisinin combination therapy. We have to remember that to prevent relapse, we have to treat Plasmodium Vivex malaria in children and adults with primaquine. 14-day course of primaquine is to be given, and the dose is 0.25 to 0.5 mg per kg body weight once per day. What if the child is G6PD deficient? Then we have to balance the risk and benefit of giving primaquine in such a setting. So we have to give 0.75 mg per kg weekly for 8 weeks. But then again, as I said, we have to balance the risk of the hemolysis occurring and the chances of developing a relapse. Coming to typhoid, I think all of you are aware and treating typhoid day in and day out. So we all know that if it's a severe illness, then indoor treatment is recommended with Ceftriaxone. If by chance there is concomitant hepatitis, you may choose cefotaxime. And an outpatient department treatment is to be given by cefixime. Again, second line, if there is by chance penicillin allergy, then you can choose azithromycin. The doses, we are aware, ceftriaxone 100 mg per kg per dose, and cefixime oral is 20 mg per kg per dose with a maximum of 1.2 gram. Azithromycin, if it is required, it is at 20 mg per kg per day, and the maximum dose is 1 gram. Duration of treatment, how long to use? So 7 days after defervescence or 14 days, whichever comes later. If azithromycin is used, it is to be given for 7 days. We have to remember that if there is no defervescence after 7 days, but the child is less toxic with a subjective improvement of, say, improving appetite and decreasing intensity of fever, then we have to persist with the same antibiotic till at least 10 days to see if the fever is disappearing. And most of the times we'll be rewarded for our patients if there is already a subjective improvement in the first few days. What is the role of steroids? Is there any role of steroids in typhoid? So only in severe illness, if there is, for example, shock, coma, or altered sensorium, dexamethasone is to be given the dose of 3 mg per kg followed by 1 mg per kg 12 hourly for 2 days. What about treatment failure? So no defervescence or the child looks toxic and there is no even subjective improvement with increasing fever spikes after 7 days of starting of optimal treatment, then that is called as clinical failure of treatment of typhoid. We have to, in such situations, rule out certain things. For example, if there's a complication like an abscess formation or the child has progressed to hemophagocytic lymphohistiocytosis, we have to look for co-infections like a malaria or hepatitis B or sometimes even a dengue. Whether there's drug fever or thrombophlebitis, or if the child was culture negative, then we have to review our diagnosis with a careful history physical examination and probably repeat a set of investigations or go for the next line of investigations. In a case with resistance, if ceftriaxone resistance, as Sanjay sir was saying, that there are cases of ceftriaxone resistance which they are seeing in Mumbai, then the azithromycin is the drug of choice, which is to be used if it's a stable patient. However, if the patient is unstable hemodynamically or if the disease is severe, then meropenem is the drug of choice in a resistant case. We have to remember quinolones are contraindicated in children in treatment of typhoid fever, and there is no role of aminoglycosides because they act on the extracellular area, whereas the typhoid is intracellular organism. If there is a recurrence of fever 2 to 3 weeks after initial resolution, even after adequate treatment, then we have to call it relapse, and relapse is not very uncommon. I would expect sir would agree that there are at least 1 or 2 cases after every 10 cases where we get a relapse of typhoid. And the treatment is with the same drug. So you need not change the regimen. It is the same drug. Usually the relapse tends to be milder than the initial infection. Coming to the last of the infections discussed, that is the ricket cell infection. And these are the case definitions, suspected clinical case. Here there is acute undifferentiated febrile illness of 5 or more days with a compatible history and examination in the absence of alternate diagnosis. Probable case, here suspected case with or without SR, and defervescence with anti-rickettsial therapy. So the anti-rickettsial therapy is a therapeutic trial which will confirm our diagnosis of rickettsia in several cases. Of course, Wheel Felix and positive IgM ELISA may be helpful. And a confirmed case is one which is rickettsial DNA detected in SR sample or whole blood by PCR, or a 4-fold rise in antibody titers on acute and convalescent sera by IFA. What is the treatment? So if you are suspecting, for example, there's a history of travel to an area with a high prevalence of rickettsial infections, then you can start empiric treatment without waiting for the confirmation. As I said, there is a way to treat rickettsia with a therapeutic trial. The other thing to be remembered is we are not to stop the treatment on basis of negative tests only, because many of the tests may be falsely negative. However, if you are not sure about the diagnosis or there are some other concomitant life-threatening conditions, then while awaiting the confirmations, you need to treat those conditions as well. Doxycycline remains the drug of choice irrespective of the age. Route is oral preferably. Dose is, if it is a small child, less than 40 kg, 2.2 mg per kg twice daily. If it is more than 40 kg, then 100 mg twice daily. You have to give for 7 days or 3 days after fever subsides, or for 10 days in a complicated or severe case. Alternative drugs like macrolides, for example, azithromycin at 10 mg per kg per day for 5 days, or chloramphenicol, which we rarely use, or rifampicin can also be used if it is if there are some problems or there's a rare chance of doxycycline resistance. So this is a typical flow chart which has been given in literature. Compatible clinical scenarios suggestive of epidemiological features in the absence of definitive alternative diagnosis. And it's a suspected case. If it's a SRs present, then it helps. If there are suggestive laboratory features, then you can go ahead and treat. If there is defervescence in 48 hours of empiric doxycycline therapy, you label it as probable case. If laboratory diagnosis is available, if less than 7 days, you can go for PCR. If more than 7 days, you can go for the other tests and try to confirm your diagnosis and continue and give the full course of anti-rickettsial therapy, plus of course, supportive therapy as required. There are few poor prognostic factors in rickettsia. For example, if the child is G6PD deficient or has received sulfonamide therapy, a young infant, a shorter incubation period, an absence of rash, or a child with diabetes and delayed institution of anti-rickettsial drugs are some of the poor prognostic factors in the case of rickettsia. So as we were discussing the syndromic approach, and this is the same article which Dr. Sane sir has quoted from Indian Journal of Critical Care Medicine. If it's a case of, this is, you have to remember from an adult journal or an adult perspective. But if we are getting a case with fever with thrombocytopenia, then of course we have to give the avoid antiplatelet agents like aspirin, anticoagulants, give IV fluids, watch for bleeding, dyspnea, shock. Platelet transfusion is a controversial issue depending upon the clinical situation and platelet count. No role of steroids and specific therapy once diagnosis is established. If the child is having jaundice, then antibiotics for control of fever, injection ceftriaxone, tablet doxy if there is a chance of epidemiological history suggestive of rickettsia. IV fluids, keep a watch for urine output, seizures, encephalopathy, and bleeding. FFP or cryoprecipitate may be rarely required if there is bleeding. Renal failure is not very common in our setting, so I'm going to skip that. If there's a child with fever and respiratory distress, then you have to, of course, start antibiotics, IV fluids, oxygen by Venturi mask, injection ceftriaxone, injection azithromycin. You may consider oseltamivir if H1N1 is a possibility. And you have to watch for impending respiratory failure, shock, renal failure, as well as alveolar hemorrhage. And if it's a fever with encephalopathy, then you have to start appropriate antibiotics, IV acyclovir, intravenously may be given. IV fluids need to be started. Mannitol if there's raised ICV. We have to watch for seizures and specific therapy once the diagnosis is established. So with this, I'd like to end my presentation, keeping it open because I know this topic is going to be a little more discussed topic. Thank you.
Thank you, Dr. Sanjay, for a very nice presentation. And you really covered everything very well. And there's not much that I have to add to what you said. Just 2-3 things. One, in dengue, I just wanted to talk a little bit about the use of platelet transfusion and steroids. So as you rightly said, that in uncomplicated dengue, there is no role of giving platelet transfusion. Unfortunately, that is which makes the parents most nervous because the child will be well, but the platelets will be 20,000 or something. So there's no role. And in fact, studies have shown that, in fact, use of platelets has led to more complications like Trali. So unless, of course, the platelet goes below 10,000, then maybe one could give it, but not otherwise. The second is many people use steroids in dengue fever, especially if the platelets are low. So I think steroids should be used only if there is features of HLH and multi-organ dysfunction, but not otherwise, because there's no data to support that use of steroids hastens platelet recovery. And third is, what is the name of that drug which people used to use? Papaya leaf extract. Yeah. So papaya leaf extract, also capsules and all are available. There was one study which showed that, the recovery in platelet count was faster, but and maybe hospital stay was lesser. But I mean, again, that evidence is not proven. And I've seen actually children who are given raw papaya leaf who vomit and their condition becomes even worse. So for dengue fever, that is what I wanted to add, that no platelets, no steroids, no papaya leaf extracts. Then the second point which you made about malaria, of course, we don't see it, but you said we only have artemether-lumefantrine available. We don't have the other combinations. They may be available with the National Malaria Eradication Program because they use artesunate and sulfadoxine pyrimethamine. Of course, there's one more product called arterolane pipraquine, which is available by a company called Synriam. That can also be used. And even in falciparum malaria, a single dose of primaquine is indicated because of 0.25 mg per kg to reduce gametocidal gametocidal effect. And if you can't use primaquine in Vivex malaria because of contraindication, then you can give suppressive prophylaxis with chloroquine, like 10 mg per kg weekly, 5 mg per kg weekly for 2 to 3 months. And the use of primaquine every week for G6PD deficient people is only applicable for mild to moderate G6PD deficiency, not severe. So if your G6PD report on the qualitative test comes abnormal, you have to do a quantitative test to figure out how severe is the deficiency. That is there. The other point about typhoid fever, which I wanted to say, is that please don't use routinely combination therapy, because many people start with both cefexime and azithromycin. So I don't think there was one trial from Nepal which showed a slightly quicker defervescence with use of both the drugs, but in clinical practice, it's generally not indicated. And you were very right to say that if a patient is on ceftriaxone and the fever is coming, you can remove the IV line and switch to oral and see sometimes the fever goes away. I think that is all I wanted to say. And about rickettsia, I just wanted to say that we had actually, I just want to recount this case which we had where, we had this child who had fever which was not subsiding. He didn't have a rash, but he came from a rickettsia endemic area. And that patient had already been given azithromycin for 5 days and his fever didn't get better. So he was sent to me for opinion by Dr. Shailesh Barot. He practices in Virar. And he sent a wheel felix, and the wheel felix was like 1 in 640 or something of OX2 and OX19. But I thought that how can this be rickettsia, because the patient has already received AZ, which should work for mild rickettsial illnesses. But nevertheless, we gave the patient doxycycline and he got better. So, sometimes we may have patients who have got AZ as part of their initial therapy for fever and who are not getting better, and you think that it can't be rickettsia. That's not true. I mean, in my personal experience, this was the first time I saw a child where azithromycin didn't work well. Of course, the other important thing is that his serology suggested that he had spotted fever and not scrub typhus. So I think the role of AZ is more for scrub typhus than it is for spotted fever. And you can safely use doxycycline in children of any age. It is not contraindicated. That's it. I mean, those were just the comments. And now I think we can open it for general discussion.
Pallavi madam, can you allow everybody they can unmute or mute themselves so they can ask if they want, please.
Yes, yes.
There are many questions in the chat box. Majority of them has been answered by madam. Now the last question which I see is, which is better option to continue, IV ceftriaxone or oral alternative in a case of typhoid fever which is responding to the treatment?
Always shift to oral, because what happens is many patients are sent home on IV ceftriaxone. The poor people keep coming every day for the injection. It causes thrombophlebitis and other problems. So if the patient's fever is away, please shift to cefixime. There is no role of continuing IV ceftriaxone.
Okay. Then one more question from Dr. Abasar Patankar. Empirical non-responsive fever in a suspected case of typhoid, doxycycline or azithromycin, what is to be preferred?
I would investigate for cause of fever. I would not give empiric therapy, because the first time you have already given empiric therapy. In fact, you'll be surprised many of these patients will turn out to be tuberculosis. You do a CT and you'll find necrotic nodes.
Yes.
So unless you have a patient who's coming from a rickettsia endemic area and there are other things which suspect, then maybe you could use doxy. And if you really are suspecting rickettsia and you want to give empiric therapy, then please use doxy, don't use azithromycin.
Question regarding Ceftriaxone, madam has already answered. Then dose of cefixime also you have mentioned here.
I think previous questions I've answered.
Yeah. Almost
yes.
Though this is a session of tropical infections, but still sometimes during the investigation, somebody comes with the ultrasonography of abdomen showing the lymph nodes. So how to interpret that 1.5 or 2 centimeter lymph nodes, whether that it is related to treatment of fever?
No, but because I haven't seen a single child who doesn't have those mesenteric nodes, But I think in typhoid, you may want to give them importance, because if you see some terminal ileal thickening with mesenteric nodes and splenomegaly, then it may be a subtle indicator of typhoid. So, but the ultrasonologist has to be good to pick up the other things, because if you just find mesenteric nodes with the other things not present, then it is very non-specific.
What is the role of this bone marrow culture? Suppose patient of PO suspecting this typhoid. So it says bone marrow may be positive culture.
We shouldn't do bone marrow just to confirm typhoid, because we should send for culture if we are doing a marrow to rule out leukemia or some other disorder, just for the purpose. See, because, most of the times by now, typhoid has already got excluded, because what do we generally do in clinical practice? We start the patient, we have a patient with suspected typhoid, we send the test, we start IV ceftriaxone. Then after 5 to 7 days, the patient is not getting better. We know that this is not typhoid. Then there is no point in sending the bone marrow culture. Now, it is too much to assume that that patient has ceftriaxone resistant typhoid. That's why he's not responding to typhoid, to the antibiotics. That's taking it a bit too far.
How common is the immunological fever in the typhoid? So this is not responding. The infection is gone. And there is
but is it culture proven typhoid or not? That's the most important thing. Yeah. If it is culture proven typhoid, we should not, we should think if after 7 days the fever is not going, then it is a clinical failure. It's not an immunologic fever, and you should not be using steroids here. Okay. So if you will have patients who have typhoid fever, who will be sensitive to ceftriaxone, who will not respond after day 7. And that's called as clinical failure, because the drug is not penetrating the cells well. So there you will have to change to azithromycin.
Dr. Sanjay Deshmukh, you have raised hand. You want to ask
your
question? Dr. Nilima and Dr. Sanjay, 1 minute. Down the line, if one thinks of doing blood culture and antibiotics are going on, so what is the duration of the time when we should stop and send the blood culture, and it will come effectively positive?
No, it's not recommended. That's only applicable for infective endocarditis, not for typhoid fever. So if your patient is on antibiotics, don't stop antibiotics, wait for 2 days, because as the time passes by, the culture positivity declines. And Salmonella typhi is not like Haemophilus influenzae or, pneumococcus, which will disappear with just 1 dose of the antibiotic. So you can straight away send the blood for culture.
Okay. Yes, Dr. Sanjay, sir.
Yes. My question to Dr. Singhal, Tanu ma'am. In dengue-like illness and dengue fever, we have all recommendations regarding the platelet transfusion. And if the patient is hemoglobin stable, we're not transferring the baby with the platelet transfusion. But what happened in our own experience, if the platelet is 40,000, and if consult the patient, we are not going to transfer the baby with platelet transfusion, and after 1 day, the count go below the 20,000. It's a very difficult dilemma, because they says you have to transfuse the baby with the platelet transfusion. That's why the platelet come ho gaya. So, madam, how will you tackle these things?
See, actually, I don't know about you, but if you have actually given platelets to these people, you'll find it makes no difference to the platelet count. It is like ITP. You give platelets, it has to come down, And there are studies which show that it makes no impact. It actually increases the risk of TRALI. In fact, 2 people landed into the ICU. So the problem, with IAP is that in our country is that we don't have any IAP guidelines on dengue fever. We should have them. That has been proposed several times, because if you have a IAP guideline statement which says that do not do platelet transfusion, then you are safe, because medico-legally you are not going to have a problem.
Yes.
You will have to counsel the patient, and that is why I specifically alluded to that, in that it is sometimes difficult, but you should put it in the other way. You should say कि platelet से बच्चे का फायदा नहीं नुकसान होगा, उसको breathing में problem हो सकती है, उसको ICU जाना पड़ सकता है, उसको कोई infection HIV HBV लग सकता है. You can say all these things actually. I mean, they may not be entirely true, but you can actually counsel the patient. But yes, if it is, and I don't know, in my practice, I've never seen the count go below 10,000. Somehow it just stops after, 14, 15,000 hota hai. And in these patients, what we do is we start monitoring the platelets every 12 hours. But yes, below 10,000, I think there are now guidelines from the hematology where they say up to 5,000 also you can accept the count because the risk of CNS bleed is not there. Is there such a recommendation about prophylactic platelet transfusion? Most people use a cutoff of either 5 or 10,000.
We use 20,000, madam, because on the safety side.
And only if you are doing some procedure, like acid या कुछ करना है, then I think that is the prophylactic transfusion is required. Recommendation.
Yes. So that is only for a procedure. Procedure, though, you may have to maintain it at 50,000 also, But but sometimes CVP and all those things you insert, you give platelets and insert immediately, because you will find that if you've given the platelets 6 hours before, also it will drop down. So you just let the platelets run and you do the procedure. That's what we usually do in practice.
Sanjay sir, you wanted to say something?
Yeah, I think 10,000 is more acceptable figure for a transfusion. If it is less than 10,000, and of course, if the child is bleeding, then we should do irrespective of the platelet count. So that I think I remember as a guideline for transfusion.
Yeah, so don't use 20,000. 20,000 is now very, very liberal. So I think 10,000 is better.
There is one more question. Role of procalcitonin to differentiate infective and inflammatory fever. Kulkarni sir, you want to answer this?
Absolutely no use. There is no difference. You see, MISC procalcitonin is one of the inflammatory marker which rises. So practically it is useless.
So, procalcitonin, I think the role is more in the ICU. In these common community-acquired infections that we are dealing with, it doesn't have a real role. Maybe in leptospirosis, it will be high, but you will often see in typhoid, it is not elevated. So it is not such a good test in this kind of setting.
Right.
So, and it's an expensive test, and whatever information you need, you get it from CRP. So why do a procal?
Okay. One more question is, when we are shifting from IV to oral, cefixime or cefopodaxime, what is the preferred?
Cefopodaxime has no role in the management of typhoid fever. There is just one trial. We don't even know the dose. So definitely it is cefixime. Please don't use cefopodaxime.
One more question is, which is more suggestive of dengue, low WBC or low platelets?
No, I mean, the only thing in dengue you see is that you see a decline of both WBC and platelets, and this is very remarkable. So day 3 only your WBCs can drop to 2,000, your platelets can be 70 to 80,000, which doesn't happen in any other illness. But I can't say which is more. And in severe dengue, you can actually have a high WBC count also. So the only thing which I know is that the recovery in the WBC count starts before the recovery in platelet count. So that is always seen, that your WBC starts recovering, and then once your WBC starts recovering, your platelets may still be going down, but then now that the platelets will recover.
Even the WBC falls earlier than the platelet. The fall is also early. And you can predict usually that once the WBC is stabilized, that is the time when the platelets are going to be at the lowest ebb usually.
Yes.
The last question here is there any role of immature platelet fraction?
I don't know. I mean, we don't do it. I mean, immature platelet fraction may be elevated, but there are some people who say that if you have a high IPF, you may predict that the platelets will rise, but practically I've never used it in. I don't know, Dr. Sane, Dr. Kulkarni, Dr. Sanjay, do you have anything to add?
One case I remember, when the child had delayed, she had a thrombocytopenia which was lasting way beyond the usual time limits. At that time, the IPF was looked at because the hematologist was consulted and he was suspecting a virus-induced bone marrow suppression. So at that time, the IPF helped out and showed us that it was just a matter of time and the platelet counts were going to increase. But otherwise, routinely, we do not look at it.
So, of course, sometimes you may have a dengue-induced ITP also. So that we have had a case or two where, the platelets just don't pick up, the IPF is high, and actually the patient, then you have to give them IVIG or steroids.
So can I say something?
Yes.
I think gone are the days when we were chasing platelets now. We have stopped chasing platelets and we look at the stability of the patient. And that's why I think IPF has not much role, except like what Sanjay said and what Dr. Tanu said, that in an unusual patient, when we want to see recovery of thrombocytes, then we might look at it. Otherwise, it just, I think WBC rise is far better and earlier indicator that now after 48 hours, the platelets are going to rise. It's typically after 48 hours, yeah.
So something which helps me in my practice is whenever I ask a patient with dengue to repeat a CBC, I tell them upfront that I am doing the CBC to look at the hemoglobin. I am not going to look at the WBC. I'm not going to look at the platelets because ये तो नीचे हो जाने वाले ही हैं. I tell them in advance कि ये तो नीचे जाएंगे ही. हमारा main concern CBC करने का है कि वो hemoglobin को देखना है. And the moment you tell that, because suppose some patient is also recounting the CBC to you now, सबसे पहले they will tell you the platelet count only. Then they might tell the other thing. So I upfront only tell them that platelets are going to go down, but if the child's blood pressure is fine and the hemoglobin is stable, we are not worried.
I have one question to ask Tanu and all other experts, that why WHO guidelines keep on talking about PCV and not hemoglobin, and we keep on, looking for hemo concentration, or every time we look at hemoglobin and we are quite happy with it, but all the guidelines keep on talking only about PCV. Is there any difference between hemoglobin and PCV? Why should we do that? Or is it on field PCV is very easy to do? Is there anything reason?
Yeah, because earlier I remember when we had the dengue epidemic in Delhi, it was not possible to do CBC so frequently. So we had the what is that called? That machine, which spins, which we used to do bilirubin and all, and centrifuge. So we used to remember, we used to take capillary blood, because you can just take capillary blood and spin it and check the PCV. That is sometimes easier.
So it's a faster method probably. Yeah. Thank you.
Other thing is that for bleeds and sudden loss of blood, PCV is more reliable than hemoglobin. It takes some time to stabilize the hemoglobin. So PCV immediately reflects the current state of this RBC content. So PCV is more reliable for hemorrhagic condition than your hemoglobin.
Okay, I mean, the logic doesn't, but I think it might be true. But logically, if there is a loss of total blood, then hemoglobin and PCV should both go down. But I think Dr. Kulkarni is saying that there must be some reference, and I accept that, I think. Thank you.
I think the questions are finished and we have reached 11 o'clock.
Thank you.
We'll wind up.
Yeah.
I'll hand over the things to Dr. Amol Pawar, Secretary Maha IP, for concluding.
Thank you, Nilima ma'am. Thank you, respected today's mentor, Dr. Tanu Singhal ma'am, then Mentees, Dr. Sudhir Sane sir, Dr. Pramod Kulkarni sir, Dr. Sanjay Natu sir, for sharing your knowledge on tropical infections with all Maha IPNs. All the diagnosis part, investigations part, and management part have been covered very well by all three of you. And it was nicely summed up by Dr. Tanu Singhal ma'am. The question answer session was also very informative. And everybody got the practical inputs for which will be helpful them in day-to-day practice. Today, we all are fortunate to learn more tips on this diagnosis, treatment of such infections. I'm sure all attendees must be having same thoughts. I thank Dr. Nilima ma'am and Dr. Sanjay Deshmukh sir for moderating today's session. On behalf of Maha IP, I thank all delegates on Zoom and YouTube platform for their patient hearing. Dates of next mentor and mentee session will be shared soon on WhatsApp groups. Thank you one and all.
It's next Friday itself.
पुढची activity declare करा.
Next Friday itself.
Thank you very much.
Yes,
Thank you.
Thank you, sir, for your time, sir. Pramod sir, it was a marathon session.
Yeah, it was a quick and excellent revision for all of us. Yes.
Thank you all esteemed faculties and Maha IP.